Kia ora and welcome to this presentation. We're talking about the general examination of people that present with the probability of some sort of acute cardiac syndrome. And in this particular presentation, we're going to be talking about some risk stratification tools that we can use in that setting. We already have established that as little as 1/3 of all the people suffering from some form of acute coronary syndrome are going to present with an ST segment elevation on their ECG. This means that the bulk of chest pain presentations that will be seen by paramedics are going to remain undifferentiated by the ECG findings. Now, I realise this is not new information for you, and that you'll already be aware of the existing kaupapa that we have around this, which is to state that all chest pain is cardiac till proven otherwise. The gold standard in this setting, or the testing that we need to establish, is done by a biochemical assay of troponin levels. And troponin, of course, is a very specific marker for myocardial damage. So here we have the situation of undifferentiated pain where the ECG hasn't changed, and we have to recommend troponin testing as a result. Now, of course, troponin testing is not required in the presence of ST segment elevation. Entry into the national STEMI pathway can be based solely on the ECG findings. So to state the obvious again, this means that there's clear evidence that the risk is already totally maximised, and further stratification of risk in this setting is entirely redundant, and the CPGs in particular outline the course of action that is required from that point in time on. What we're going to be discussing today is the use of a calculator for undifferentiated pain. It's known as the heart calculator, and it's available through the MD Calc app. Now, the calculator itself is designed to stratify the risk of a major adverse cardiac event after someone presents with cardiogenic pain. And the risk that it's looking at is the chance of this major event occurring within the next 6 weeks. So just to harp on about the obvious again, it's of no value when we're presented with someone who's got an ST segment elevation ECG, as no further risk assessment is going to be required. So the rules in this calculator are much better aligned to risk calculation in the setting of undifferentiated chest pain, where there aren't these overt ECG changes. For this calculation, I'm looking at this calculator as being an inclusive process. That is something that's more likely to rule in the need for further testing than it is a rule out process, and it's safe to tell people to stay at home. What it does is provide a framework for looking at evidence that raises the suspicion index for a cardiac event. And it may also help raise concerns or inform patients about the recommendations that we're making for them. It can be a very powerful tool to actually show someone the calculator or discuss that this will be exactly the same method that a doctor would use to determine whether further testing is required. Furthermore, without point-of-care testing for troponin, there remains the need to recommend transport for ED screening. In this sense, it supports the existing heurism that undifferentiated chest pain poses a very specific risk for most people. So without point-of-care testing, paramedics should always recommend transport or some other form of getting the earliest troponin testing done as possible. So let's go ahead and look at some of the specifics in the calculator. Heart is a mnemonic, so the first thing we're going to look at is the H, which stands for history. So the history element investigates the risk associated with the nature of the chest pain. Now, we used to see a very distinct pattern of central, retrosternal, crushing pain radiating to the left, but chest pain is now acknowledged to include epigastric pain, non-centralized pain, the so-called atypical referral patterns, which might be more to the right side or through to the back. The description of pain may be described as sharp, although in most circumstances it's more likely to be some form of pressure or discomfort that patients are talking about. Now, in terms of assigning scores with this calculator, there is a subjective element. So there's no definitive criteria for assigning a score of 1. the clinician has to determine whether the score will be 0, that is, there are very little suspicious, or whether they're moderately suspicious, while there's some more specific pain characteristics that would indicate that they were highly suspicious. So let's have a look at these. High risk presentation in terms of pain include any pain that radiates, particularly if it's going to the jaw, arm, or shoulder. If the pain is described as a pressure or a discomfort and it's associated with nausea, vomiting, or diaphoresis. If the pain is exertional, in terms of it occurs at particular forms of physical or emotional stress, or if it's pain that can be likened to a previous acute cardiac syndrome presentation. And finally, pain that responds to nitrates. So the presence of any one of those factors will result in a score of 2 on the calculator. At the other end of the spectrum, we have very low risk presentations, and these are the pains that we normally associate with more pleuritic findings. So these sharp and highly localized pains that are more positional. And in terms of the musculoskeletal system, any pain that's replicable by palpation or particular forms of skeletal movement tend to be very, very low risk. And another thing that can make pain appear to be a very low risk is if it's localized to a very, very small area, and we're talking about something that's maybe the size of a $2 coin. An important consideration is gender differences in the location, nature, and the associated symptoms of cardiogenic pain. In their meta-analysis of 8 studies, Devon et al. Revealed that women are more likely to present with an upper left-sided chest pain, more likely to radiate to the left, the jaw or the shoulder. Back pain was a far more frequent finding, and especially fatigue, dizziness, and dyspnea that was associated with this. Syncope definitely occurred more frequently in women than it did in men. Recognition of cardiogenic pain in women obligates the clinician to explicitly use some close-ended question to establish the absence or the presence of these symptoms, and then use open-ended questions to explore the patient's concerns. And maybe this is more likely to reveal the fatigue and the dizziness or the not quite feeling right, which is very much more prevalent in women than it is in men. What might not be clear in research is what the most likely presenting complaint is going to be for women. However, if it is pain, it's more likely to be expressed as a pressure or a discomfort. The next element that gets looked at by this calculator is changes on the ECG. This element investigates changes other than the overt ST segment elevation. And as I've mentioned before, if this is the case, then the analysis of risk is superfluous, and we've got plenty of other work to get on with. So in the absence of ST segment elevation, the high risk signs we are looking for is any lead that has more than 1 millimeter of ST segment depression in it. We're also looking for Whelan sign. Those are the inverted or the biphasic T waves that tend to predominate V2 and V3, or other suggestive ST wave changes. So the presence of any of those will score 2 on the calculator. So just to recap this, the high risk elements are ST segment depression and Whelan sign. Medium risk ECG changes are the other ST changes that would often be more likely to be associated with different causes than ACS. And these might include the benign early repolarization that can be seen quite often in younger people, the mechanical strain patterns that are often seen in hypertrophy or other acute conditions such as a pulmonary embolus, or we might see the ST changes that are associated with hypertrophy, so that is the Cornwell or the Sokolow voltage criteria for LVH is present. So these changes will still score on the calculator, but they'll score a 1. And low risk changes, the ones that would score 0, is if the ECG has no alterations on it. The next element is age. This doesn't take a lot of explanation. It just suffices to say that the risk of cardiac events increases with age. And so the calculator will issue a score of 2 for anyone who's over 65 years old and a score of 1 if the client is between 45 and 65. And below 45, that's a free pass. The next one we're going to look at is risk factors. Now, this element of the calculator looks at these risk factors that increase the likelihood of a cardiovascular event. Now, they're stratified into two broad groups. The first group is where there's confirmed pathology already existing. And the second group is where there are factors that may predispose towards those pathologies. So to satisfy the requirements of the first question, confirmed risk is an established history of atherosclerotic disease. Now we determine this when we take the medical history of the client, and it's going to reveal a medical event for which the etiology or causative factor is in fact some form of vessel disease. And this is going to include any of the following: a past medical history of revascularization procedures. So someone who's had any stenting done or perhaps a cabbage is indicative of revascularization procedures and is a sure sign that the person has got vascular disease. A previous myocardial infarction or a history of either transient ischemic attack or cerebral vascular accidents is also indicative, as is a written history of peripheral vascular disease. The second broad group, in comparison to confirmed risk, is risk factors. So risk factors are historical factors predisposing to atherosclerotic disease formation. Another way of looking at this is to say that the confirmed risks are events that have happened, and that risk factors are the things that may cause these confirmed risks to occur. In the absence of a confirmed risk, 3 or more factors will score 2 points. 1 or 2 factors will score 1 point. And if there is no risk factors, then obviously it's going to score 0. And the risk factors that we're specifically looking for are hyperlipidemia, hypertension, diabetes mellitus, cigarette smoking, this family history of coronary artery disease, or obesity, which is technically defined as a BMI over 30, but probably requires some sort of subjective view from the paramedic. So just to recap on risk factors, a confirmed diagnosis of atherosclerotic disease or a medical event linked to this will always score 2 points. Now, if a client hasn't got this sort of history but does have 3 or more of the risk factors, they're still going to score 2. 1 or 2 risk factors in the absence of confirmed atherosclerotic disease is going to score a 1, and if there are no risk factors, we will score 0. Again, this really emphasises the importance of closed questions to include or to exclude many of these things from the risk stratification. It's essential to accrue this information to allow this to happen. The last scoring domain for the calculator is troponin levels. I know they're not within the capability of ambulance operations at the moment, but I just wanted to discuss them briefly. So as an overview, troponins are a group of proteins associated with muscles. They act in the actin-myosin bridge, and therefore they're either going to play a role in muscle contraction or muscle relaxation. Now, they're very tightly bound within that actin-myosin bridge, and under normal circumstances are going to have a very minimal presence in the bloodstream. Now, some of the subtypes of troponin are very specific to cardiac muscle, and they'll be released from that bridge into the bloodstream when the myocardium is damaged. Therefore, they're a great marker for cardiac damage. Increased troponin levels are usually detected between 2 to 4 hours after the onset of an injury, and they remain elevated for about 7 to 10 days after the event. The release is proportional to the amount of damage, and troponin levels tend to increase over time. So there tends to be 2 diagnostic features around using troponin levels. The first is just a single reading higher than what the expected range would be. And in the setting of other symptoms, this is considered to be diagnostic of acute myocardial infarction. The general rule of thumb is to pursue subsequent testing anyway, and on the off chance these levels should fall by more than 20% from the original findings, there may be some revision of the diagnosis. However, when troponin levels tend to be higher than the expected range, the prognosis for an adverse event remains very, very high. The other path for diagnosis using troponin is when you encounter readings that are mildly elevated. Now, these will always be retested, and an increase of more than 50% over 3 hours is also very indicative of myocardial infarction. At this time, high sensitivity troponin testing is not immediately available in ambulances. I know some rural centres have high sensitivity testing, allowing ambulance crews to negotiate direct access to CCU and cath lab at tertiary centres. This is very apparent in settings such as Central Otago, where without such testing, a patient may have to endure maybe 3 hours of travel before testing can be undertaken. Sort of puts them on the back foot in terms of diagnosis and treatment. So let me just recap where we're going here. The calculator is not specific to the likelihood of ACS in the here and now, and instead calculates the short-term risk for the patient over the ensuing 6 weeks. However, it does offer paramedics structure as a rule-in process and provides objective support for the existing heurism that we employ to look at all pain as cardiac pain until proven otherwise. In the absence of troponin testing, patients can still score moderate to high risk. And so the tool can become really useful in terms of convincing people about what our recommendations are and what course of action needs to be followed. Still, please recall that in the absence of high sensitivity testing, we're always going to make strong recommendations to have troponin testing completed in a timely fashion. And we know that ED visits are the preferred location for metropolitan and semi-rural centres, whilst more distal areas may have access to point of care testing. Now, I hope this has been useful and provided some structure you can use around these rule-in processes when we're assessing risk for people. In the meantime, I wish you all the best. Ka kite.